I'm Dr. Paul Kuo at Stanford University, and I'm here in Dallas at the Liver Gala with Dr. John Vierling, Baylor College of Medicine. And Dr. Vierling has just shared his insights about some key seminal trials that have just been published, and we hope some new exciting therapies will be coming forward to help us manage our patients with primary biliary cholangitis. So, John, really enjoyed your talk. Just as you look to the next year or so, with the imminent approval of these new therapies, how is this going to change your management strategies when you see people with primary biliary cholangitis?
Well, Paul, the field, I think, is quite optimistic that with the approval of elafibranor, a PPAR alpha and delta agonist, and seladelpar, a pure PPAR delta agonist, for second-line therapy in PBC, that we're seeing not only an advanced potential to decrease the probability of progression of disease in patients who had an unmet need on prior therapy with ursodeoxycholic acid, but also for the first time to address some of their needs with respect to quality of life. So patients want to live longer for sure, but they also want to feel better. And I think it's a combination of those things that are going to be important in our field and our application of these two new therapies.
Yeah, I agree with you. Particularly, I think, one of the big challenges that we have in primary biliary cholangitis, ursodeoxycholic acid has been with us for now decades and certainly mitigates the disease injury in many of these individuals. But as you said, quality of life issues still creep in this primary biliary cholangitis population, pruritus, fatigue, other effects like that. Have you used other PPARs just in the management of these complications, just to get an idea about how these might be incorporated into our practice?
I actually haven't done that personally, Paul, because I think one of the roles that we covet as academicians is to participate in discovery research. And so to that end, I created Advanced Liver Therapies at the Baylor College of Medicine to study new devices as well as new drugs for therapies. So I've preferred for patients who have unmet needs to try to enroll them in appropriately powered and well-conducted clinical studies. Well aware of off-label anecdotal experiences with fenofibrate, the only approved PPAR alpha agonist that we have in our U.S. armamentarium, and all of us are aware of the outstanding reports from France in their randomized controlled trial of bezafibrate, also a PPAR alpha agonist. However, those two have among the potentials are idiosyncratic hepatitis. And that alone has given me a pause, although thankfully we now know from the larger experience that this is not a major concern in terms of quantitative concern, but for an individual patient, it does represent a potential toxicity. So my preference has been to talk about those things that are approved and those things that are yet to be approved and urge whenever possible that the patient consider participation as a volunteer within these randomized controlled trials.
Yes, in our center, we actually did participate in some of these trials as well. Just anecdotally, in some of our patients who don't qualify for these trials, for instance, overlap syndrome, et cetera, that were incomplete responders, we did try in a few of them just PPAR alpha fenofibrate, and actually did see that there was further improvement in the alkaline phosphatase. So I think not only in the clinical trials, but also we can see that this class of medicine is really going to hopefully move and advance the field forward. And actually, it was kind of interesting. Just we've been able to see across the trials and off-label use that particularly pruritus seems to get better. When you start somebody on ursodiol, how are you monitoring, and what do you consider an adequate or a reasonable response that's going to make you be satisfied with the initial response to ursodeoxycholic acid versus when will you start thinking about considering an adjuvant therapy, second-line therapy, to make sure that the response is optimized?
Well, the answer to that question actually hinges on sort of a historical perspective. Once, as you've pointed out, we only had first line therapy, so there wasn't much of a consideration. We used it and hoped for the best. We now have the advent of second line therapies with the FDA approval of obeticholic acid in 2016, and now the upcoming anticipated approvals of both elafibranor and seladelpar as PPAR agonists. So now the question becomes, how do we start the ursodeoxycholic acid with the intent of seeing its optimization of benefit, which is going to be played out as an observation based on the patient's response, but also to help that patient not be a person who considers themselves intolerant of the drug because it remains the backbone drug. So, one of the concerns using a weight based dosing, which is 13 to 15 milligrams per kilogram per day in a society with increasing body weights, is whether you start the full dose all at once and whether or not you, in addition, subdivide the dose initially into smaller doses taken several times a day with an ultimate goal that in those that are tolerant, we well know that they can take this drug once a day and it will then do everything effectively because it becomes part of the enterohepatic circulation, cycling in each individual 8 to 10 times a day. So it is important to note that if you go full dose in heavy patients, you actually, even with ursodeoxycholic acid, can precipitate pruritus or worsen existing pruritus. And that, when experienced by a patient, is often their focal point of not wanting to be on that drug because of its disruption to their life, their employment, and their activities. So I like to start the dose at about half dose to three-quarters of a dose, spread it out perhaps even to 4 times a day, and then consolidate this to the full dose. Now, once we've got them on the full dose, and in our experience, the quoted rates of intolerance are higher than what we observe. What we observe is, of course, anecdotal, but it is about twice as high as we observe in practice, having done that since the 1990s, even before the FDA approved the use of ursodeoxycholic acid for PBC. So now we have the question of, when do you know what the how optimal the response will be in an individual patient? The I think most revealing uh, quantitative measure of that is the continuous variable globe score, which looks at the age at which you started the ursodeoxycholic acid, then looks at the biochemistry a minimum of 12 months later to determine your score and to say, prognostically, are you benefiting from this ursodeoxycholic acid? Now that we have increased information about the value of terms of long-term outcomes of normalizing alkaline phosphatase and placing the bilirubin less than 0.6 times the upper limit of normal as a dichotomous set of variables that optimize long-term outcomes, I think we can look at this and will be looking at it differently. And this is definitely going to be true when you look at elafibranor and seladelpar, both of which have the capacity to normalize alkaline phosphatase while maintaining normal total bilirubin. So in that respect, I do not know exactly what the cut point will be, but I think prospectively, we're going to be able to make decisions about the need for second line therapies, not a year or after we
Yeah.
start, but within probably 4 to 8 months of starting, so that we are able to give the patient a sense of purpose in our assessment of their response and individualization to their needs.
Sure. So just for the purposes of the GI fellows who are watching this, if a fellow is in clinic with you and you see a new PBC patient, are you asking them to start 500 milligrams once a day, twice a day? Let's say they weigh 70 kilograms, just as a hypothetical.
Mm.
Are you asking them to try it as an initial dose by itself? Do you start it just at a low dose and twice a day and titrate the dose from there? What's your preferred method to try and introduce the ursodiol?
Well, to simplify the hypothetical, let's say they were going to need a total of 1,500
Okay.
milligrams, and we were going to recommend 500 milligram tablets. I would have them feel comfortable in taking 500 milligrams once a day. When comfortable with that, I would move it to twice a day and then finally to 3 times a day. And often at that point, because they haven't experienced anything in the interim, then we can say, look, we could keep this at 3 times a day, or we could go to 1,000 at one dose, 500 at another. Or if you feel comfortable, we could give the whole dose all at once. And then the question is, what time of day does one do that? And patients have often expressed a preference, since the fact that you have the enterohepatic circulation involved in this process, that they would take it at a time when it's more convenient for them, and less likely to be a missed dose. So if they get up late, they're not going to go off and forget their morning dose. But many of my patients actually take it at bedtime, because they can kind of keep it there. It's a time that they relatively control, and it's not usually a time they take any other medication, so they don't have a sense of pill burden.
I agree. And I have now evolved toward giving it as a single dose, either in the morning or the evening. Patients actually, as you indicate, are much less likely to miss it. And you try and just select in your routine what is the most reliable time for you to take your medicines. And I remember many, many years ago when Ursodiol was first introduced, that the Europeans were using daily dosing, and we were stuck on twice a day and 3 times a day. And I just didn't realize that indeed, if it's introduced well, then you can tolerate the dose without really too much in the way of side effects that would discourage them from taking the ursodiol. How often are you measuring liver tests in the first year? Do you bring them back quarterly? Do you, just to make sure? Because we always want to monitor not only for response, but also to make sure they're truly taking, tolerating and taking their medicines.
Well, that's an important question, and it has, I think, two dimensions. Is what we and the patient might negotiate is preferable, and what insurance may feel comfortable with in terms of monitoring. Because as our practice is a consulting practice, it's subspecialized practice, we sometimes have to deal with issues of prior authorization to see patients back. So we would like to test things, and what we would do in a circumstance where we might have an authorization to physically see a patient back in our practice every 6 months, if we've initiated therapy, we will check labs only and review and then comment back to the patient, either for telemedicine or in our electronic medical record communication to the patient, the 3 month data. And again, we're looking to help them have a trust in the therapy we have recommended by demonstrating its effectiveness. Now, we explain that in 3 months, we will not see the full effect, but we should see the beginning of an effect. So they're usually quite happy to do the test and to have the results showing such an effect. At that point, we then would decide, based on what the effect was, when we might next monitor. We might monitor another 3 months, for example, could be 4 months. We definitely are going to be monitoring everyone at a year, because we have excellent data that can be utilized for calculation, in this case of the Globe score. But this also is something that needs to be part of the patient's understanding and decision. Because as I shared in my lecture, there are data that suggests that the trust the patient has in either or their first line therapy, in this case, ursodeoxycholic acid, or a second line added to that therapy, has a great positive impact on their perception of quality of life.
Agree. And when you're discussing the results with patients, when do you decide that you've reached the nadir of the alkaline phosphatase? In other words, say you started with an alkaline phosphatase of 6 to 700, and the next one is maybe 200, 180. How often, as you get closer, are you still bringing them back quarterly, or how do you decide, or how many alk phos measurements do you think you have to see before you say, well, it's time to start considering an adjuvant, if I'm getting a suboptimal response?
Well, if we look at absolute numbers, one has to be patient with long term therapy. And the multiple mechanisms of action of ursodeoxycholic acid also correspond to why you want to look at optimized outcome late. And in the original development, late meant after one full year of continuous daily dosing. So that is sort of a consideration that we have to have. Remember, I want to look at 3 months just biochemically, not have them back with an office visit and all the attendant details and extra cost, because I want to know that they're taking it, they're benefiting from it, and to explain that to them to establish this trust. Now, if I have an alkaline phosphatase that starts at 600, I do not expect that to be 200 in 3 months. I don't expect it to be 200 probably even in a year, because the delta here is so great that we'd have to have a tremendous percent drop. And a percentage drop that's more than about 45% in a year is not usually what one sees. And in fact, when you look at the most recent trials of second line therapies, elafibranor as well as seladelpar, achieved just above a 40% drop quite rapidly, and then it was sustained. So it's not continuously down. So we have to be patient when they have a baseline value that's quite high. And when I get to 200, you're really at usually the variation in the upper limit of normal within different labs, usually around 200. You're quite at or just beneath 1.67 times the upper limit of normal. And now I have credible evidence to share with the patient that they have achieved a surrogate benefit outcome. And they are very happy to hear that. Thereafter, I don't feel that I need to monitor that frequently, but will do so in conjunction with the patient. And I will probably make it every 6 months.
Got it. So while you're managing these, how do you manage the pruritus if you don't see improvement? Ursodiol, in my opinion, some people, their pruritus does improve. Others, it just remains a refractory issue. What are your approaches to try to ameliorate the pruritus effects that people get with PBC?
Well, if we look at pruritus and we look at ursodeoxycholic acid, I think that the best credible information comes from the combination trials that were published originally from Poupin in France, using also a French Canadian series, Jenny Heathcote in Canada, and then Keith
Right.
Lindor in the Mayo Clinic when they combined their
Right.
databases in the original URSO studies. If one critically looks at those databases, you come away with the idea that ursodeoxycholic acid has no significant effect one way or the other on pruritus. So I think pruritus remains a baseline. And in fact, the frequency of pruritus in urso-treated patients at the right dose would attest, I think, to that. So I would look at pruritus and tell my patients that I do not expect ursodeoxycholic acid itself will make an impact here. But it does vary among patients. It comes and goes, and it worsens in intensity and lessens in intensity. So if the patient feels there's a temporal relationship of improvement, I'm not going to argue them out of that opinion, but I will indicate to them that we may need an additional therapy for treatment. Now, the only randomized controlled data available and, kind of sanctions by the Cochrane database are the randomized controlled trials with resins, and that was cholestyramine in terms of the specific bile acid binding resin. And I've used that quite successfully, but there is a very difficult educational step with the patient. And that is that by reducing the amount of bile acids that can be absorbed in the terminal ileum and recirculate to the liver and back into the systemic circulation and back out the bile, is putting a small drain potentially into the size of a very large bucket. And what we're after is reducing, in a metaphoric sense, the water level of that bucket beneath the threshold of itch. We don't know how high that water level is to start. We don't know where that threshold, where itch would cease, is. But we do know that with continuous treatment, we have a good prospect of getting there. But this can take weeks, sometimes even months, very frustrating to patients who believe that whatever effective drug they take should work within minutes, hours, or days. And you're saying, well, it can still be effective, but it worked yet. I think that when we look at further treatments of pruritus, I have had um, strong um, hesitancy to use rifampicin as second-line agent because of its drug-drug interactions. It has three major gene effects, all of which distort drug metabolism and can create drug-drug interactions. To date, as I shared in the lecture, over 718 have been published. And our patients are generally on multiple drugs. So polypharmacy is the rule rather than the exception. And I don't want to distort that, nor do I want an hepatotoxicity from rifampicin, which can occur as an idiosyncratic reaction. So I tend to go to second line therapies after cholestyramine, to naltrexone, or to sertraline.
Yeah, and I think sertraline is one that has a reasonable side effect profile as well. Not everybody responds, but it's quite dramatic when they do. And actually, sertraline, I agree with you, also has a nice added advantage. Even if your liver disease is more advanced, it's one of the better tolerated SSRIs. What do you think about these emerging therapies? Do you think these IBAT inhibitors ultimately are going to help play a role in the management of pruritus in the future for this and other cholestatic diseases, just as it has in some of the pediatric congenital diseases?
Well, I think that the pediatric data are outstanding proof of concept that in significantly inhibiting the terminal ileum bile acid reabsorption and thus changing the total bile acid pool is going to be beneficial for pruritus. Now, it could also have a certain benefit with protection of cells, which might be undergoing intracellular cholestatic damage as you change the total quantity as well as the proportionality among the different bile acid species. So I think that it has an excellent potential. It's only going to be realized with the results of randomized controlled trials, which are underway. And we anticipate that they're likely to be positive trials. And I think this would be a great adjunct to our therapies.
Agree completely. So, just to wrap up, and thank you so much. When you have fellows with you in clinic and you're introducing them to the diagnosis of PBC and how to manage them, if there are one or two pearls that you would like to share just in the evaluating these individuals, what do you think are the most important things fellows should be considering when they see their patients who come in for PBC diagnoses?
Well, I would actually probably answer in three ways. The first and foremost is to understand that AMA negative PBC does exist, and you can augment your potential to diagnose it accurately by testing for GP210, SP100 anti nuclear antibodies, which are highly specific for PBC. So I think that we add to everyone's knowledge that AMA should be tested, that in circumstances, especially AMA negative patients, you want to test those two autoantibodies to help diagnose the AMA negative population. The second thing that I would emphasize is that once we have a credible diagnosis, it is very important to work on the education of the patient that ursodeoxycholic acid is a proven first line therapy and needs to be taken on a daily basis, currently indefinitely. Now, that's important because when we interrogate large databases for the ICD 10 diagnosis of primary biliary cholangitis, we have pharmacy records in the US that say only 79% of patients are taking ursodeoxycholic acid. So if they're not taking that, they really are not treating the disease adequately, and it needs to be a consistent treatment. It's only with that consistent treatment that we'll have the ability to know what the true population at need for second line therapies actually is, and have a chance for the future development to work toward normalization of alkaline phosphatase as well as the reduction of bilirubin to less than zero point 0.6 times the upper limit of normal, which I think are going to become our new treatment surrogate guidelines and endpoints for further trials. The third thing that I would emphasize is that one needs to pay attention to Paris criteria and the guidance that's coming from EASL, APASL, and the AASLD regarding the diagnosis of so-called PBC AIH, autoimmune hepatitis overlap. That diagnosis, when one looks at the literature, has expanded enormously in the proportion of patients thought to have overlap, and a time frame that would suggest that biology must have changed regarding the pathophysiology of the involved disease processes. I think the time's too short that that actually happened. I think we are overdiagnosing this as an overlap. And you already mentioned that this was one of the barriers of many patients being able to participate in clinical trials. They actually do have PBC, not overlap with AIH, and yet they are specifically segregated and are not allowed to participate in trials, nor are they really candidates for the therapies that are under development. So, yes, overlap does occur, probably at a frequency much less than we currently have in our operational practice. And it's the initial clinician and hepatologist that must make the distinction using specific diagnostic criteria.
Yeah, I agree with you. I mean, that's been my main experience in people with, as we discussed, fibrates, is because they couldn't get into a PBC trial. And although the biopsy was compelling, and as you just said, there is in some people some inflammatory infiltrate, not just confined to the portal tract in these individuals, but it can be it is not necessarily AIH, and I think hopefully there will be some standardization of this over time where you will be able to distinguish, if you will, what I would consider biliary based fibrosis versus just a hepatic fibrotic process. Just to wrap up, one last question. Just how would you counsel a fellow who calls you and said that you've mentored and says, Dr. Vierling, I just saw a woman who has a positive AMA, but came to me, ALK Phos normal, GGT just above normal. She's asymptomatic. What do I tell her? Particularly now we're diagnosing more of these individuals with more widespread screening. And how have you involved in your advice to these patients?
Well, that too has evolved. There was a time, and it was substantiated by a study performed in Italy, where they looked at screening that included AMA. And when they found those that were positive that met such criteria, they then followed them with the idea that they would ultimately develop a truly classic PBC with elevations of GGT and alkaline phosphatase. Now, we look at that study because not everybody did develop it over a period of looking over 5 years. Then we look at other studies that say that a leading edge might be GGT elevation as opposed to ALK Phos, which is moving within the normal range but remaining in it. And then we go back to the oldest of the studies in which AMAs were detected using indirect immunofluorescence in the UK, where Oliver James was sent a number of patients that were AMA positive, completely biochemically normal, and he had biopsies for several of them. Now, again, anecdotal, but those biopsies showed classic lesions of lymphocytic cholangitis indicative of PBC histopathology with completely normal biochemistries. So all three of these observations have taught us that there is a preclinical, pre-biochemical phase of PBC, and that in the AMA positive group, which is generally right around 97% of the population with the disease, that would be the biomarker of such patients. So that led to the concept that if you have the findings of the patient you described, in a matter of time, if followed sequentially, they will develop PBC. Now, we fast forward and find that when you screen with autoantibody panels, that AMA can be found in anything from acute liver failure patients to MASLD patients to some patients with chronic hepatitis C. We published and presented information regarding such events, and we didn't know that they didn't fit the original paradigm because they hadn't been observed long enough. So we've observed 5 to 8 years in this patient population and had nobody becoming cholestatic and looking like they had PBC. And talking anecdotally to others, I think it's been most observed in patients who have MASLD, which was not surprising because that might be quantitatively just much more liable to come to testing within our system because of its sort of epidemic proportions. So I think right now the answer is it's possible this person is immunogenetically predisposed to PBC, is developing or moving through the preclinical biochemical phase, but it is also possible that it is an irrelevant autoantibody.
You wouldn't, but that's someone you would insist gets periodically monitored.
I think you're obligated to, given the fact that we know that such patients have indeed progressed to classic, biochemical, usually asymptomatic, but biochemical, cholestatic, and diagnosable PBC. And I think, are obligated to find that. But I'm no longer convinced that by long-term observation that they all will do so.
Sure. They just need to be assessed periodically. Thanks for sharing your insights. Really
Pleasure.
appreciated it.
Thank you.